Good afternoon. My name is Alpesh Patel. It's my pleasure to be a part of this discussion today. And I've been asked to talk about the use of steroids as a neuroprotective agent. And the title of this talk is Avoiding Steroids in Spinal Cord Injury, with a subtitle that this is really a case for rational thought in the scientific method. And I think if we follow those ideals, we'll end up at a very logical endpoint. These are my disclosures. There's nothing related to the topic at hand here. I think there are three keys that we should plan on trying to take away from this discussion. First, is that we have to accept that there is a lot of inherent uncertainty when it comes to the conversations around spinal cord injury. We're going to come up to that again and again and again, but uncertainty. The second, we need to define a strategy for how we will safely evaluate therapeutics, especially in this realm of spinal cord injury. And third, we want to learn how to interpret and understand what the critical determinants of surgical decision-making are in spinal cord injury. That is to say, what are the drivers of surgeon behavior, physician behavior in this setting? Because that'll help us understand what's happened with steroids in the past and what may happen with steroids in the future, let alone other novel therapeutic interventions. So in 2020, I think we have two goals when it comes to the management of patients. First, neurological protection. We may include preservation, even regeneration and recovery in that. But then also equally important are concepts around patient safety. We have to accept that treating the spinal cord alone is not sufficient. We need to treat the patient as well. Where are we in 2020 when it comes to the pathophysiology of spinal cord injury? Well, we understand primary mediators like compression, maybe even ischemia, and we think as well that there are these secondary mediators that come into play with regards to spinal cord injury. And with that, we get this primary zone of injury and a secondary zone of injury. And I think we'll hear a lot about that during the course of the meeting. And that's actually driven a lot of our current acute interventions for spinal cord injury. If we think about stabilization, rapid transport, and specialized centers, even this idea of 24/7 workforce is driven around the acuity of care. Our techniques, reduction, stabilizations, decompression, instrumentation, the idea again of a rapid decompression. And then even some of the systemic treatments that we do offer, blood pressure management, maybe cooling, novel agents, and then really this leads to the discussion of steroids. But there are many secondary mediators, not just a few. This list goes on. And to say we truly understand each mediator by itself, let alone the really complex interplay of all of these mediators is really a stretch. And I don't think that's where we are from a scientific standpoint of having a complete understanding of all the ramifications of a spinal cord injury. So that brings us to this idea of uncertainty. We have to accept that while we do know quite a bit about spinal cord injury, and many of our speakers today are the reason that we know so much, we probably know less than what we don't know. There's a lot more we don't know, and yet we're making really critical decisions, sometimes life and death decisions for patients based on our current knowledge. And that leads to steroids, right? That's what we're here to talk about. What is the current thought process on steroids? How did we get to where we are? Let's be really clear that we're talking about high-dose methylprednisolone based on the NASCAS-2, NASCAS-3 protocols. We're not talking about the small bolus of Decadron that we might give, but we're talking about high-dose methylprednisolone with an IV bolus and then an hourly infusion. That's what we're talking about. So what did we learn from NASCAS-2 and NASCAS-3? Well, from NASCAS-2, what we really learned was that there's no neurological differences. Only in a post-hoc manner, subgroup analysis for patients treated under 8 hours, which was very few patients, where there's small motor improvements, no functional score improvements, but small motor improvements. NASCAS-3, we learned that 48 hours of steroids is a little bit better than 24 hours. Certainly, if you're treated within 3 to 8 hours, you saw better improvements at 6 weeks and 6 months, but no difference by the time we hit 1 year. So what did we learn from NASCAS? Well, we learned that it's full of limitations. Let's start with methodology, because that's the most glaring problem here. If we look at the methodology of these studies, it would really not pass current standards for what we think of are high-level, appropriate clinical studies with rigorous scientific method application. It's a post hoc analysis. These seem to be very much arbitrary time cutoffs, although I think the authors have tried to state the otherwise. And it really comes across as data mining, looking for when your primary outcome didn't show a treatment effect, how can we dive through the data to find some treatment effect somewhere? There's a lot of problems around transparency. This is private data. It's never really been externally reviewed. And again, as a sign of that, this is a drug that's never gotten FDA approval for this indication. And then there's some obvious issues around objectivity. And now, again, to be fair, at the time these studies were released, we weren't as acute and aware of the issues around being objective when it comes to, especially pharma-sponsored research, the potential for conscious or unconscious biased interpretation of data. But then there's also how these studies were released to the press, how they were released to a medical audience. I think, again, in 2020 would not be what we would consider to be the best behavior or the most rigorous scientific process. So what did we really learn? Well, I'd argue we learned that in NASCUS-2, we had threefold risk of PE, twofold risk for infection, fivefold risk in GI bleed. In NASCUS-3, we learned double the risk of pneumonia, sepsis, wound infections, right? Life-threatening complications were certainly brought about by the use of steroids. So if we think about high-dose steroids in current state, really, these were the situation that we were avoiding them in. Essentially everybody. There's very, very few people that we would even think about the therapeutic use of steroids, and many, many more people that we would not use steroids in. And if we look at a survey done in 2006 of spine surgeons, less than a quarter of them believe in the efficacy of steroids. But there's a twist. That same survey, 90% of surgeons used high-dose methylprednisolone in acute spinal cord injury. So again, we're back to this question mark. What's going on with steroids? What's going on, and why are we uncertain? Well, clearly, John Hurlburt and others have documented well in the literature that a big driver of use in the early 2000s and the 1990s and early 2000s was the risk of litigation, the fear of litigation concern. If you don't use steroids, you're somehow committing malpractice, despite the evidence, despite the clinical concerns. So with that, in an update in 2013, this was a joint effort between AANS and CNS. In their update, this is level 1 review of evidence, and I'll save you from reading through all of the small font, and I'll pick out some highlights. When it comes to steroids, it's not recommended. When it comes to steroids, it's not approved by the FDA. When it comes to steroids, there's no class 1 or class 2 evidence for a clinical benefit. When it comes to steroids, there is class 1, class 2, and class 3 evidence for harmful side effects, including death. That's their summary of the data and the evidence we have available. Now, while we have new studies that have come out, and I'm sure we'll hear about these, we also have to understand that our population, especially in the United States and in other countries, is aging substantially. And with that, we see an aging in the patients with spinal cord injuries. We know these patients have a higher morbidity, a higher mortality in general. And I would argue that the best data we have currently really doesn't effectively analyze risk-benefit in this situation. And if anything, we would expect that risk-benefit analysis to be much worse for these elderly patients. So as we think about the change over time, luckily we've seen some change. From 2006 to 2013, this is a survey that we did of CSRS members. We saw a reduction from 89% of surgeons using steroids to about 56%. If we look amongst the neurosurgeons, we saw still an even more dramatic reduction. So as orthopedic surgeons, maybe we need to catch up. What else do we find? Of all of the surgeons that were surveyed, more than 70% had seen a major complication that they believed to be associated with the use of steroids. And still, about only a quarter of people feel like there's any efficacy to these drugs that we're providing people. So what does it mean for steroids? It means despite what you might hear today, it's really still more hope than it is proof. So I think we need to leave this conversation with, again, 3 things. Accept that our knowledge gap is really large. We have some really smart people you're going to hear from at this meeting, and I respect them thoroughly, but I think we all need to accept that we know less than what we think we do, and our knowledge gap is large. Second, we need to demand that accepted standards for evidence include both clinical benefit and risks and follow a rigorous scientific method. Third, we need to admit that in all of the studies that we come across, there are going to be externalities and bias that will influence our decision-making. We talked about legal risk earlier. There's also a lot of bias, affirmation bias, in how we interpret data. We want to find results. These are a a traumatically injured population. And we want to find things to help them, but we need to stick to the data, not to hope. Thank you.